Hey guys, it's Judy from Nutrition with Judy. Thanks for joining me today. While you're here, please make sure to like and subscribe. If you're listening to this on podcast, please make sure to follow the show. My name is Judy Cho, and I'm board certified in holistic nutrition. And I have a private practice where we focus on root cause healing, and that often starts with the Carnivore Cures all meat elimination diet. Today, I had the pleasure of sitting down with Dr. Laura Buchanan. We talk a lot about why medical schools don't use lifestyle and diet interventions as the first line of defense for metabolic illness. We talk through a lot of what is shared in medical schools and what she did in hospitals when she was working with metabolically ill patients. We talk about some of the tools that she uses with her patients to get them healing with lifestyle interventions. Dr. Laura Buchanan is a board certified family medicine physician with a passion for using lifestyle modifications as the first line standard of care whenever possible. She completed her family medicine residency at Wake Forest and was a valedictorian of her class at the University of Florida College of Medicine. Dr. Buchanan is the chair of the Society of Metabolic Health Practitioners, and she is currently creating a nutrition curriculum with goals to implement in medical schools, residencies, and for other healthcare professionals. Dr. Buchanan recently joined Dr. Tro's practice, and you will see a lot of what they do to support their patients. Let's get right into the interview. Hi, Dr. Laura Buchanan. I'm very excited to have you on my channel today. For the people that are listening and watching that may not know you, if you can introduce yourself.
Yeah, so I'm Laura Buchanan. I'm a family medicine doc as well as board certified in obesity medicine and also a metabolic health practitioner. I grew up loving playing sports, and then it was kind of through high school, undergrad, I started seeing in my own personal family the differences that really lifestyle and what you were eating, how it had a big role in how you age. So in a lot of people I loved seeing, different complications arise versus just my granny playing tennis until she was 88. And so that kind of got me inspired and realized, the power of that. And then in medical school, we did have a 2-week nutrition course. And by the end of it, it was just really frustrating, to say the least. There's still kind of some of the same old dogma: saturated fat is bad, it's going to kill you. And we learned the basics. You had to know, memorize, this vitamin deficiency causes this, but I just didn't have any practical knowledge about how to take what I had learned and help the person in front of me. And so around then, I just really started doing my own research. And I read Tai Schultz's The Big Fat Surprise, Gary Taub's book, Jason Fung. I found the Low Carb MD podcast and was just, my eyes were opened, and it's like, we are just missing this big time. And so I really, going into residency, I believed in low carb, and I had read about the power that an impact it had in people's lives. And from pretty much day one, I started practicing low carb, trying to help my patients live that lifestyle. And some patients, go all the way to a ketogenic diet, and others staying just lower carb, and saw great results. And so that's kind of, how I got here.
Okay. And why do you think, just from your experience in medical school, that to only teach nutrition for 2 weeks of your medical curriculum?
So I think a part of a really big issue is actually on the board exams or the step exams, which you have to pass to get your degree. They don't ask questions about nutrition. And so if they do not ask questions about it, then you are not going to get educated on it, because to get a good ranking, so you want your medical school to be high ranked, you need your students to perform well on these exams and say, all of our students perform in this percentile. And so I think that's one piece of it. It's not emphasized, and therefore it's not going to be important for the curriculum. We have all these things that are going to be on the step exams that you must pass, and we want you to do really good on. So we need to make sure that education is there.
So then, in terms of the step exam, what exactly is it? The biochemistry of the body, when something's broken, here's how to fix it. What is being taught?
Yeah, so there's a lot of that, so like you said, the pathophysiology, how the disease processes work, then a lot of medications, side effects. I can remember spending so many hours reviewing Sketchy Micro, a wonderful program, but it was memorizing all these different medications, all the side effects they had, potential interactions. And so that was a very big portion of it.
I find that so interesting because there's pharmacists and pharmacology that studies medicine and how it interacts with the body. So that's not a specialization for doctors other than that you would prescribe medications for all the metabolic illnesses and illnesses there are today. But in terms of nutrition, which really is a fundamental in how your body becomes fueled and then created from those amino acids and other foods, it's interesting that the medical space just missed that. I just can't help but wonder, is there something more malevolent going on other than, oh, it's just not part of the test? Like, who creates these tests and stuff? It just makes me wonder.
Yeah, I mean, I feel like we're still stuck in this. A patient comes with you with diabetes.
Mm-hmm.
What medication can you prescribe them? That's the paradigm, or that's
Okay.
how you're taught. If someone has high blood pressure, what medications work? What should you do? What is the progression? If one medicine doesn't work, what is the second and third line medication that you should use? And as an example, so if someone comes to you with an A1C of greater than 10, guidelines say you start that person on insulin. Well, I had a patient come into my clinic whose A1C was 14. I checked a C-peptide, just that's a lab that you can make sure they're still making their own insulin. So, it's going to be safe to not prescribe them insulin. And was like, hey, your A1C, your sugar is really high. Recommendation per guidelines is we go ahead and start you on injections, insulin, or why don't we try the ketogenic diet and see what happens? And we'll keep an eye on your sugars with a continuous glucose monitor and just watch. And the patient was like, oh, absolutely, I'll go on a ketogenic diet. That sounds great. I don't want to use medicines or insulin. And within 3 months, his sugar, I mean, really within 2 weeks, but his sugar was normal. His A1C was normal. But that's not taught in medical school. You're taught the guidelines.
Is it against your board certification? Or, I mean, could you get in trouble for sharing these other interventions other than what's part of the guidelines?
So you shouldn't get in trouble as long as you have a shared decision with the patient and you
Okay.
discuss what is recommended and then other, risks of that, benefits of that, alternatives to that. Because patients don't have to start, a medication. If they want to avoid medication, then it's your job to try to help them figure out how we can treat you without a medication.
Do you think a lot of doctors don't use these lifestyle interventions because they just are following these guidelines, or maybe they don't think other than what's being recommended, or it's just, I don't know, it's just staying in your guardrails that the medical establishment has created? Any
Yeah,
thoughts on that?
yeah, for sure. I think it's several things. I think one, there's no education on it. So,
Okay.
everything I learned about low carb and how to deprescribe medication, I was taught myself. I learned from watching Low Carb USA and reading the TCR, therapeutic carbohydrate reduction guidelines from the SMHP. And so, unless you are actively going out and trying to, learn that stuff because you either know about it or found it, you might not get exposed.
Right.
So that's one issue. The other issue that's a true, tough in our current situation in the medical field is a lot of these appointments are 5 to 15 minute appointments.
Mm.
And it is, you can imagine seeing 40 patients and you're just tired and you're like, you know what? It's really easy to say, hey, here's a medication refill. You're not having side effects. Great. I'll follow up with you again in 3 months and see how things are going. Try to eat less and move more. Like you
And
can do that in 5 minutes.
And is that because that's what insurance covers? Like, why is the patient session so short?
A lot of it is insurance driven, and the more patients you see, the better your profits. And
Okay.
so some clinics are actually the higher ups at the clinics will say you need to be seeing X number of patients. And so that, and you have, in addition to seeing the patients, where some people might see 30 to 40 patients, they have all the documentation that they have to do after that.
So typical doctors see about 30 to 40 patients a day. Is that typical?
Yeah,
Wow.
some primary care clinics and
Wow.
definitely some specialist clinics too.
And then in terms of, I know you worked with Dr. Eric Westman in his clinic. What did you notice there, and what illnesses did you see him overcome with just lifestyle changes?
Yeah, so that was incredible. So I spent 1 week with him and am so grateful for that. In the 1 week, we had about 35 return patient visits, and there was over 1,300 pounds of weight loss in those individuals. We saw, I think he had deprescribed maybe 10 medications during that time. I saw patients whose heart failure got better, their kidney disease got better, their gout. one patient had been struggling with terrible brain fog since having COVID, and the brain fog went away. Anxiety, depression, insomnia, thyroid. I mean, it's almost, you don't believe it because you're like, well, it was incredible. And he was able to do these not in super long visits, but he had 20-minute follow-up appointments.
Okay.
And he was able to help keep those people on the right track and help them with questions they had in that time period.
And then do you practice low carb keto, or is it just a spectrum of lifestyle changes that you recommend?
I primarily, or me personally, or for my patients?
For your patients.
Oh, yeah. So I primarily do low carb keto.
Okay.
I do have a few people who might not be wanting to do low carb or keto, and they're just otherwise want to make sure their labs are okay and be healthy and age well. That's mentally, physically, socially, but for the vast majority, and now working with Dr. Tro, people are coming to see us to learn how to live a healthy low carb keto lifestyle.
Can you share a story of a patient that has healed so much stuff, illnesses, maybe even the mental addiction side of food, but a story of healing just by changing? And I know that's just is not really just, it's a hard change, but the lifestyle, whether it's diet, movement that you've seen in practice.
Yeah. And I'll say a lot of it, for many people, the physical activity or movement is very important, but really these changes and a ton of these benefits are happening with the dietary changes. And then once they make those dietary changes, they have the energy, they feel good enough again to actually be more active and be physically, out and doing things. But it's, a couple different stories come to mind. One, and this, I like this because it just shows it's never too late. It was an 80-year-old patient who was on insulin for her diabetes, and she went keto and was able to come off of her insulin and felt better than she had in a decade. Wow. Mentally. Her energy was better. She was able to be active again. And that's at 80. So people like, oh, I'm too, someone's too old to do it. No, you can always improve your lifestyle with the help of, a good team. I think sometimes it's important. And then another one, there was a kid I was seeing who at the age of 12 years old was put on insulin for type 2 diabetes. And he had been on insulin from 12 until 21. And I started working with him, helped him go keto. And he was able to come off 100 units of insulin in the course of a few weeks. Wow. And that is just incredible. You can imagine having gone through middle school, high school, working in college and working and using that much insulin that many times a day. I mean, he was on 4 shots a day, the type of impact that has on your life.
The grandmother that was 80, or the patient that was 80, how long were they on insulin, if you remember?
Years.
Oh, okay.
Yeah.
Okay. So you believe that almost everyone with blood sugar imbalances, if they were to treat the lifestyle, maybe some people have to go stricter, maybe some people have to go carnivore, but if they were to really hone in on their lifestyle, that all or most people can get off, whether it's diabetic medications or insulin.
Yeah, as long as their pancreas is still functioning, so they're actually making their own insulin, then I think so. Between, like you said, sometimes it does take someone to go carnivore and do some more fasting as well. I think if the liver is really just, both the liver and the pancreas are so filled with fat that it's not responding appropriately, and they just have these large swings in blood sugar, even though they're eating meat only, then sometimes the fasting helps with that.
Okay. Yeah, I've seen that too in the carnivore community, where people have really high A1Cs or insulin markers, and in order to reduce it faster, they would have to do some level of fasting.
Yeah.
Do you feel that when people start fasting, if they do have those high levels of diabetes or blood sugar imbalances or the insulin, that they may have to work with someone to be able to monitor, maybe if they're taking insulin, for example, that they would have to work with someone to ensure that they're taking a safe amount with that fasting?
I think definitely if someone's on insulin, you should be working with someone who can safely de-prescribe it, because some people, their blood sugar drops so incredibly fast. And if your blood sugar, hypoglycemia is truly a life-threatening event. And so any type of medicine that can drop your blood sugar dangerously low, so sulfonylureas as well, I would be working with a provider that knows how to de-prescribe that.
Do you think there's any illness that this lifestyle can't support?
I think one is glycogen storage disease type 1, which is a contraindication maybe to the ketogenic diet. And there's a few other very rare, specific, like carnitine transferase deficiency. So there's a few things like that, but those individuals that have those diseases, they know that. I mean, they know exactly. They have a very specific dietary pattern they have to stick with. And so it would be rare that you would come across someone that you might accidentally put on a ketogenic diet that would seriously harm them.
Okay. You mentioned that in hospitals, there would be people there for amputations, diabetic complications, and then the diet wasn't ideal. What, if you can explain a little bit about that?
Yeah, I'm laughing, but it's very sad. It's like you said, we'd have patients coming in with their diabetes out of control, and they would be needing an amputation. And you go see them the next day after the amputation, and they would have pancakes and syrup, and you're just like, it breaks your heart. And sometimes the patient knows, but then other times they don't realize exactly how it is truly what they are eating that is driving that. Maybe they haven't had or at least understood that education. But then in the hospital setting, you can imagine as a patient, if you're offered that, then it's kind of like, well, I guess this is okay.
Right.
I know they're going to give me extra insulin to bring my sugar down. And so that was, too common of an experience for sure. And some patients I spoke with at the hospital was like, hey, this is truly what is driving your disease process. If you eat this and this, your sugars are going to be immensely better. We don't have to give you the extra insulin. You'll be at lower risk of additional complications. And some of them were appreciative. There's one instance, a gentleman who he was not there for an amputation, but his sugar had gotten over 1,000. And so so you see that occasionally. So we had the dietitian go and talk to him about diabetes and what he should be eating. And so I just went to follow up with him to see how the educational session went. And he showed me the nutritional advice he had gotten. And it was eat at least, oh gosh, was it 30 grams of carbs at every meal? You need to have 15-gram carbohydrate snacks at least multiple times a day. And I was like, oh my gosh, he's in here with a sugar of 1,000, and this is what we're advising him. And so I sat down, spent an hour with him, basically talking about the ketogenic diet. And he looked at me and he's like, first, thank you. Second, this is ridiculous. Why did you tell that other person to come talk to me, like that you work together? So I could see his frustration and the confusion. So I think that's it's a tough spot.
Yeah, I always find it interesting. Before I ever got into nutrition, my grandmother was diabetic. And if she took her metformin and the blood sugar dropped too much, we would have orange juice and lifesavers on hand to regulate it. And I remember always thinking, that is so weird that we are giving her sugar to balance the medication when the medication is trying to lower the sugar. And I thought that was so weird, but I just assumed the doctor knows best and her blood sugar does not know how to regulate. So we need to sometimes fine tune it. And that was just the logic I had for it to make sense. And I just wish I learned about it, all of this nutrition stuff earlier, because I think she could have lived longer. She was taught to just eat the brown rice instead of white rice, right? It was just, and like you said, have little drips of sugar all the time. And we would have her not eat processed sugar, but she was drinking fruit smoothies. So there would be 10 fruits in one smoothie and she'd be downing it. And we're like, this is healthy for you. And if her blood sugar ever went up, we just thought, okay, you just take some more metformin. It's such a broken system.
Yeah. We need the education to spread. I mean, it needs to go into medical schools, but PA, nurse practitioners, and then we really need to get more help and education within the dietitians, because they are educating so many of our patients on with their diabetes. Oftentimes in clinic, if you get a patient with diabetes, there will be something that pops up, referral to diabetes education. And so, at residency, I actually stopped doing that. I would click decline because it was just, they were getting opposite of what I was telling them. And so I said, but if we can create a system where that's not the case, then that would be incredible.
Sometimes my cynical brain thinks, well, will that ever happen when the Dietetic Association gets funded by the food conglomerates and there's all this extra funding outside of, we see Nina titles trying to fight the food pyramid and the food recommendations. And it's just, you see these little needles and it moves a little bit. I mean, so they did reduce the sugar a little bit, but they still demonize saturated fats. And I just wonder, will the policy ever truly change that the hospitals recommend a ketogenic diet? And maybe it will, but I also think just educating the people and making it more of a grassroots movement is the ultimate way that will change. I don't know. What are your thoughts with that?
Yeah, I think probably you're right. Through the grassroots movement is going to be the biggest chance of success. But I also think through organizations like the Society of Metabolic Health
Right.
Practitioners, hopefully we can make a dent, and the Nutrition Coalition and working together. And we're actually working on right now a nutrition curriculum to hope
Oh,
the goal is to be implemented into medical schools, PA, nursing programs, and even dietitian schools would be awesome as a way that people don't have to do what I did, which is learn all of this on their own, but actually are given it, educated on it, and then they don't have to use it, but they have the education just like they do on how to prescribe these medications correctly.
yeah. Yeah, that makes sense. I mean, that is amazing if that happens. Um,
Fingers crossed.
we talked about in medical school how sometimes they just don't share about nutrition because it's not in the testing. But why do you think there is some information that just goes against the low carb movement? For example, a lot of the carnivore community, they get worried that their doctor's like, if you eat too much protein, your kidneys will get damaged. The
Yep.
other one is obviously cholesterol. If you eat too much cholesterol, you'll have a heart attack, especially from animal-based meats and fats. Why do you think they share that science?
Yeah, so a lot of that, well, I start with the heart disease. So there's nutritional epidemiology studies where they give people food frequency questionnaires, which is maybe a 90 to 140 questions about what you ate in the past, could be weeks, months, or year. And you go through this questionnaire really, and you say how many hamburger patties you ate.
In a
And
year.
yeah.
Okay.
And what's crazy is, so when you eat a hamburger patty, what do you often eat with? One, well, you've got the bun, you've got whatever else you added to it. Maybe you have a soft drink, maybe you have some fries on the side, maybe you got a milkshake too. And the food frequency questionnaires are not accounting for that. They can't control for that. And so you get these tiny, tiny numbers that really aren't statistically significant anyway, or clinically relevant, that says people who ate the greatest quantity of red meat had a 0.1% higher risk of heart disease. But that's when, again, you can't control for all of those other variables. So it's useless. I mean, it is truly, you can maybe create a hypothesis using nutritional epidemiology, but that is it. And people make these big claims, eggs are good, eggs are bad, from studies like this. Or red meat causes colon cancer, same thing. I tell everyone they should go and take a food frequency questionnaire and just see how ridiculous it is, because they'll have you do one or two and then follow you for a decade or 2 decades and without any further questionnaires, and just say what happened. And in my lifetime, and I've 2 3 decades, my dietary habits have changed a ton. So
Right.
if you do one questionnaire on me, that would be totally different if you took my questionnaire now versus 8 years ago. But you wouldn't catch that in the data.
So when they follow your story, are they just seeing your health ailments, the health progression, and not just any dietary changes?
Exactly.
Okay.
Yep.
It's
You
crazy.
do those baseline questionnaires and say, all right, 9 years later, what happened? That's what you're basing on. And that is a lot of where the dietary recommendations and guidelines have actually come from. So I do not put any stock in those studies.
What about the excess protein causing kidney damage?
So with kidney disease, they've looked at studies that was basically looking at, it's hard to explain, but nitrogen balance.
Mhm.
And I mean, the big takeaway, actually, maybe I'll go there, is in people who do not have kidney disease, there has been no studies at all that have shown a high protein, low carbohydrate diet has been harmful to people. And there's actually some now data coming out that potentially higher protein is protective.
Mhm.
The In patients who do have CKD3 or greater, there is some data that protein restriction could help slow kidney disease progression. And the further your kidney disease progresses, the more protein restriction might be beneficial. I think a lot of more studies need to be done, because you think about the number one cause of dialysis is diabetes.
Right.
And what drives diabetes? It's blood sugar. So if the number one cause of dialysis is driven by high blood sugar, then it's probably not the excess protein people are eating that are driving this progression of the disease, right? And so we just, if patients already do have advanced kidney disease, they do need to work with someone and probably keep an eye on it. And there's definitely anecdotes and talking to other people in the low carb field who have seen kidney disease improve, and I've seen it as well with creatinine function improving on a low carbohydrate diet. But there need to be larger studies in that population before we could start giving recommendations on it.
Yeah, it would be interesting to see if somebody that has chronic kidney disease, and if some of it's related to diabetes or blood sugar imbalances, once they improve the blood sugar dysregulation, could they still be eating more protein? And my guess would be yes, from the carnivore community. But in the medical literature, there's not that much of that yet because they don't look at the kidney illness with diabetes and then see how that affects protein consumption. So I agree with you. I think that makes a lot of sense just to look at that.
One of the big new medications now to protect the progression of chronic kidney disease are SGLT2 inhibitors. And what those medications do many things, but the big thing is they make you pee out blood sugar. And they also can increase your ketone levels a little bit. But that protects the progression of kidney disease. And there's so much research and so much money being spent on these medications. It's like, well, what also makes you not have blood sugar to pee out? And what also raises ketone levels? The ketogenic diet. But there's not, a pharmaceutical company with billions of dollars researching that.
Of course.
Yeah.
I know you work with Dr. Tro now, and I heard him say that 99% of all his patients turn back to food when they're in a stress state. So how does your team deal with that? And how much of that is related to food addiction?
Yeah. So the stress is a huge piece of it. When at the end of a workday, you've already made so many decisions, your stress is high, and you just don't have a lot more to give basically in that day. And so if you don't have a set plan in advance, or you've got some candy in the pantry and your brain is kind of like telling you should go get that, that piece of candy, that's going to feel really good, then odds are you're going to go get that piece of candy. And so really a huge piece of it is having a plan. Set yourself up for success in advance when you feel really good, because when stress is high, when things get tough, it's really hard. To use willpower in moments like that is just not a good thing to rely on. And so, that could be many different things to plan ahead, but we like to talk about having a safe environment everywhere you go. So at your home, have some low carb replacement options. So if you do get a craving for candy or cake, you've got that, whether it be a Quest bar, something to really help you. If you've got purse bacon, so when you're out and about and people are eating, or you get a really, people are cooking something in the workroom and it's pizza, and like, wow, that smells really good. You've got something, a good alternative for you. Same thing in the car. Sometimes for some people, driving by certain restaurants or fast food is a trigger to go through and get what they usually got, the milkshake, whatever it might be. And so again, having a set plan in advance, but while you're not stressed, I think is key. That's one of the biggest things as far as having a plan when the stress is high, because it is so true. That is the most common time by far you hear, oh, I went off the wagon because work was really tough, or I had an argument with my significant other and I just needed to feel good. And the processed foods, the sugar rush, the dopamine, it makes your brain release dopamine, and it will make you feel good shortly, briefly, but it's a drug, right? And so that's how it's being treated.
Yeah, I think that makes so much sense. So I struggled with an eating disorder for a really long time. And then when I went keto and I was trying to go low carb, I had to, certain fast food places or certain grocery stores or certain places I used to go to, I would feel the emotions of anxiety of, I need to not be here because I'm starting to feel that I need to buy certain things I used to buy. So it becomes like a reminder of old past habits. And now I don't have that, but it just took time to really, I guess, work on that muscle to not have that restraint and then no longer have those sugar dopamine remembrances affect me. But it took a while to get there. And so the environment is so critical. We have a client right now where their significant other works for the Mars candy bar company. So they have candy bars
Mhm.
all the time
Oh,
at the
yeah.
home. And it's a trigger for him, and it's just hard. And so I basically told our team that you need to have him have the hard conversation with his wife that she can't have the candy bars at home because it keeps tripping him up every single day. And I'm sure it's after a day of hard work where he just wants to relax, and he knows there's all these candy bars all over the house. And it just is a conversation of we need the environment to be cleaner for now because I need to get over this hump because he keeps struggling because of it.
Yeah. Yeah, exactly. And like you were saying with those, like driving by certain places was, it made you feel those emotions again and brought
Right.
you back to that and those cravings. I mean, that's the same thing we hear if people who are addicted to heroin or opioids, if they drive by a certain corner where maybe they used to buy drugs off of, they get the desire, the cravings, and that we everyone accepts and agrees that that is a very powerful addiction, and we see the harm that it brings into people's lives. And food addiction is the same thing, right? I mean, we know it is bringing so much harm into people's lives, and people are having the same type of responses, the emotional responses. They're still the same type of cravings and withdrawal symptoms even. And it needs to become more accepted that this is what we're up against and what we need to help people deal with, because it's not just as simple as, necessarily for some it might be, but not for everyone, to say just go on a ketogenic diet, you'll be better. So if they're dealing with a food addiction, you've got to really help them understand that, and then kind of maneuver and again set up. There's just a lot more pieces that go into it if that's what you're up against.
Yeah, I think one thing about food addiction that's so difficult is you have to test yourself every single day with foods, and
Yeah.
certain things will trigger you to say, well, today I wasn't quote unquote on plan. And so therefore I'm going to cheat. But I think that's where, for me personally, carnivore was so powerful, where carbohydrates are no longer on the table. It's just complete abstinence, which then
Yeah.
gave me freedom. And then I found I guess, a happier medium eventually nowadays, where if I want to have a little bit of veggies, I could. But generally speaking, I just thrive better on a meat only diet.
Yeah.
But how does that work for people that are truly suffering from food addiction, where any bit of sugar or something sweet lights up those dopamine receptors?
So I think that's a great point. For some people, I think it does need to be abstinence,
Okay.
meaning, like you said, you're strictly going carnivore, you're not using the replacement items. But for a lot of people, I think if they can use the replacement items, that actually makes it a sustainable lifestyle.
Okay.
So when their birthday comes around, being able to have that keto cheesecake or that keto cake really makes it work. And it doesn't send them back into going back for the higher carbohydrate foods or kind of down a spiral. And so that is just, I think, very specific. A lot of people I've found, they will initially, again, using the replacements can really help when times are tough. And then slowly you kind of wean off of the replacements. Because the goal is to be eating mostly whole, real foods. Everyone kind of agrees that's the healthy thing you want to do. But again, when times are tough or cravings are hard, sometimes using those replacements does have a spot. I know there's a little bit of debate kind of if using them versus no, it needs to be abstinence. But I think you've just got to work with the person in front of you
Yes.
and find what works.
Yeah, agree. I think it really depends on the person. Some people, those alternative foods are the bridge that they need to really get them healing on keto. And I've seen that a lot. For me personally, those keto treats triggered me to do other things. So
Yeah.
I completely agree. And I think the debate is because there's no one answer. I think it really depends on the person in front of you, seeing their habitudes, if there's been a previous food addiction. And then based on those things, they can determine what will give you the end result of consistency, because that's what truly will make people better. It's not whether you had a keto treat or not. That is it's like negligible in the long run. It's really what will allow you to stay mostly low carb, mostly keto, real foods, and that will ultimately bring most healing for most people.
Yeah, exactly. And that's the goal, right? You want the person in front of you to feel better
Right.
and reverse their disease and help them age successfully. And
Yes.
so that's however you get there. I'm not very picky,
Right.
but
Agreed.
that's what the goal is.
So One of the biggest complaints I get from a lot of my clients is I try to go to my doctor. I heard of C-peptide online, or I've heard of fasting insulin. Some providers don't even test A1C. I feel like it's more common nowadays, but or I want to get a CAC score, and I try to get that from my father. And the Kaiser Permanente said we do not do that testing. And I was shocked by that. And then other thyroid markers. So most providers only tested TSH and not the other things, not the antibodies. Why is that happening?
So again, a couple different things. I think one is a lack of education again. So when I first started residency, I was ordering fasting insulin on people. I was ordering calcium scans. And initially, when I would go and precept, because you have to go up to the attending and kind of tell them your plan, they're like,
Right.
whoa, this person doesn't have diabetes, or this person's LDL is 160. Why are you getting, or 120? Why are you getting a calcium score? And so I'd have to explain my logic and my reasoning and kind of some of the research behind it. And so that was just really, I think, the lack of education. And eventually I stopped actually getting pushback, and people were seeing the results of some of my patients, and it just became accepted. The other piece is, again, kind of going back to more guidelines. It's not necessarily recommended to get an insulin on people, because the thing I often hear is, what do you do with that? And it's like, well, you could do a lot of things with that actually, and you could catch insulin resistance way before they actually develop diabetes. But same thing with the calcium score. It is now in the guidelines, but it's for people with a certain percent of risk, basically. So if you are someone who is strictly to the guidelines, which many docs are, then they don't have that wiggle room to work with the person in front of them. They'll say, no, we're not going to do that. I don't think it's going to benefit you, because they believe the guidelines are basically so good and evidence-based that you should not go against them.
It's so crazy to me. I mean, doctors are so brilliant. They go through so much schooling. And then, because I saw this in the consulting space too, a lot of the eye bankers, the management consultants, they get the best and brilliant in all the top schools. And then all they end up doing is, this is the way you do these things. And there's no questioning about what you're doing. So everything is this straight path. And then they get the best and brilliant minds to do it too. And I just remember thinking, I don't like my job in the consulting space. And it's the same. It sounds like
Yeah.
when you're a provider and you've gone through all the schooling, there's these guidelines and we don't question beyond that. And it just drives me crazy. It's just insane.
It does, because I mean, questioning is a great way to learn. It's how you make guidelines better, because
Right.
they need to be updated. I mean, 50% of what we learn in med school, this is the statistic you always hear, is not going to be true, but you don't know what 50% is not true. Thinking about that, like, you have to be questioning, you have to have an open mind. I mean, back maybe 10 years ago, I didn't eat red meat because I thought it was going to give me colon cancer and cause heart disease. And now I eat red meat on a daily basis. So that was after I went and read the data for myself and realized the data does not support what is being taught and recommended.
Do you think that you're naturally a more inquisitive person? Because I just wonder, like, what made Dr. Buchanan so different than Dr. Smith, that doesn't question the guidelines?
Yeah, I think a lot of it was my upbringing. I have four brothers, and they are all very questioning as well. And I think they gave me a lot of like helpful pushback, and would question it. And when I would say things like, "Oh, don't eat that. That's going to hurt you because of this," they'd say, "Show me the data." And so then I'd be like, "Oh, well, I don't really know, but I know that's what I was told." And so that definitely helped. And then my better half, my other half, Matt Calkins, who he's also a family med doc, he is, when we met right before medical school started, and he was a physics major, so he approached things very differently and was incredibly inquisitive and questioning of things, and wanted to understand the root cause and really get down into the nitty gritty. And so sometimes that would annoy me, but really that has made me such a better doctor and better person, really, because it's created such a deeper understanding of things. So it's been really good to work with him and learn medicine together.
That's awesome. So does he also advocate for a low carb diet as well?
Yeah.
Okay. Okay.
Yeah.
You talk about the false advertisements of keto products as well as that heart healthy Cheerios. Can you talk a little bit about that?
Yeah, this one is so frustrating to me, as it is to patients and people in general, because perfect example, I'm working with someone right now whose sugar when I first met her was 460 on 70 units of insulin. And in the period of a week, we were able to get her down to 20 units of insulin with a blood sugar of 150 to 200. Then one day I was watching her CGM and her blood sugar went up over 100 points almost. It was a huge spike. And I was like, hey, you know what happened? You're eating keto. And she's like, oh, well, I ate a low carb bread and for lunch, so I don't know what did it. So she sent me a picture of the bread and I was like, oh, goodness. And it says keto on it, but it clearly false advertisement. So this is someone who is really trying to help improve their life, prevent disease. And the food companies are just sabotaging. And it's just, I think it's criminal. You shouldn't be able to call something, they should make companies test products before using continuous glucose monitors and prove this is not going to raise your blood sugar if they want to call it ketogenic. Then there's probably other, ways that you could do it. But I think there needs to be some evidence behind the claims on these packages.
But there's no body that's really regulating that. Is that correct?
Not really. I mean, they can get around by saying it's keto because of the net carb. But the net carb, you subtract out the fibers, you subtract out sugar alcohols and other things. And a lot of these processed fibers and these new, basically processed, almost like chemicals, but food things, they raise blood sugar and our bodies can absorb them. So people are like, oh, it's fiber, you don't absorb it, you'll pass through. Well, that's not true with all of these processed things. And so no, there's not a regulatory system that is intervening and stuff like this.
And is that why you like the CGM so much? I know that both of you and Dr. Cho love the continuous glucose monitor. What is it? Is it because people can then try keto treats? What is it a habitude thing? What is it?
Yeah, several things. Again, what you mentioned about being able to track or try the keto things. Sometimes, people, again, they need that replacement. And so I always say the CGM does not lie. So if you go out and you try a sugar-free candy and your sugar bumps up, it doesn't matter if it's sugar-free or not, your sugar is going up. And so that's one great thing. The other, it can be an accountability, basically tool or partner. And for me, I've been wearing one for several years, and it helps me stay low carb because I really do not like seeing blood sugar spikes. When I do, if which is rare now, but if I do, then I start going for a walk or I start lifting weights. I do some type of physical activity or movement that is going to help my body absorb those carbohydrates, those sugar. The other thing is for maybe someone who doesn't necessarily want to go keto, because say you're carnivore, oftentimes the CGM is kind of boring. You mostly get this flat line. You're like, well, it's flat line again for the 20th day in a row or 80th day in a row. But for some people, if they just want to go low carb, but they're still having some carbohydrates, then it can really help them modify how much carbohydrate they're eating, what they're eating it with, and that can actually have play a role as well.
Yeah, one thing I saw with the CGM that's really beneficial is some carnivores, for some reason, they keep waking up in the middle of the night. It's around like the 2, 3, I think it's when the cortisol point where there's that need for it. And they'll see that their blood sugar, maybe they're always in the 80s or 90s, and then it drops all the way to the 50s. And then there's a huge spike up. And so their blood sugar will now be in the 150s. And they will only know that because they had the CGM, but they always are wondering, why am I still not sleeping well? And when they have the CGM on, even as a carnivore, that's the one benefit I've definitely seen when carnivore is the CGM will tell you, yeah, there's still a blood sugar imbalance going on that it affects you in the middle of the night. So I do see that. I've seen so many benefits with the habitudes in terms of keto treats, and then people trying something or, oh, this frozen food says it's low carb or there's not a lot of carbs listed, but maybe a lot of the processed stuff in it actually raises your blood sugar too. And so people will see their spikes from that alone. And so I think it's a great tool. The one part that I don't like about the CGM is if you're eating a lot of fructose, so say you're having a lot of fruits without a lot of glucose in it, it gives you a false belief that your blood sugar is not going up as much as it may be affecting insulin. And that's the only part. I don't know if you've seen that. But that's the only part I'm hesitant where it might give people a sense of, oh, see, I can tolerate this certain type of fruit or this certain type of something because it's not affecting my glucose, but it's mostly a fructose filled food.
Yeah, no, that's an interesting point. I mean, a lot of the people I work with, I will say I still see pretty large increases from
Right.
fruit.
Agreed.
Like
Agreed.
it's large enough that it pretty much helps them. They like, oh
Okay.
wow, I'm not gonna eat fruit anymore. And so it's less common, except for maybe the berries, where people won't see any type or will see a very minimal increase in their blood sugar with the berries. And so I would love for the day we do have a continuous insulin monitor to see, and when you
Yes.
do eat those berries and there's not much of an increase, what is going on. But we're probably at least several years, if not longer, from a insulin monitor.
Right, right. And I would love that would be awesome to have that. Your goal is really to help people age gracefully, successfully, and without much ailment. So what does that look like for you and how do you support your patients to live that lifestyle?
Yeah, so I mean, it depends on where you're starting from, but so much of that is going to be driven by what you're eating because that's going to be driving so much of the metabolic disease, arthritis, diabetes, hypertension, sleep apnea that makes people feel super tired and fatigued throughout the day. And so, kind of step one is optimizing their nutrition and helping, if they have chronic disease, helping reverse that chronic disease. And then from there, really being physically active. We know there's, and primarily women, but people over the age of 65, if they fall and break their hip, there's almost a 30% mortality in the first year
Yeah.
following that, which is huge. And then even for the people who live, a large percentage of those people actually won't walk again, or they're going to be stuck using a walker or a cane. And so before you get to that point, you need to be building up your balance, your physical strength, helping keep your bone density good. And so that way, if you trip, you can catch yourself actually. You can get your foot out quickly enough so that you don't fall and you don't have
Right.
that fracture happen. So I think that's a huge piece of it that we really need to emphasize. And then also spiritual or mental well-being, socialization. I mean, we talk about blue zones and people say, talk about their different dietary habits. A lot of the blue zones, one of the big things they have in common is they have a wonderful social network. They have such an important community around them, and they're involved in their community and they age, with their community. And so having that purpose in life and being a part of something and having, whatever it might be, helping the person find those things. Why are they happy to be alive? How can we help them, find what has meaning to them?
If you were to leave any tips that you have seen for your patients that have made them be successful, whether it's sticking to a diet, the lifestyle, having them really reverse a lot of the chronic illnesses, what are some tips you would leave?
Yeah, so make a plan in advance. So if you're going out to a restaurant, know in advance what you're going to order. If it's, you're just going to order the steak, and don't be afraid to ask the waiter not to bring out the bread to the table because once the bread's on the table, that is hard to resist. So advocate for yourself. Kind of goes back to the purse bacon or, bringing, if you're at work, having something readily available. So things like that I think are really important. Having maybe a support system or someone that you can go to, someone you can reach out to when things are tough and you're like, hey, I think I'm about to lose it or I'm going off plan. Help me. Like find someone who can be there for you. And then, having sometimes just writing things down, like what is your why? Why do you want to make these changes? And sometimes even writing that on a little note card and keeping that in your purse if you have one, or in your wallet, like this is my why, that I want to be there for my grandkids. So I'm not going to eat that piece of cake. I'm going to do this. And another thing that I found some people really find helpful, especially if they're dealing with a lot more mood, like depression. Sometimes when depression hits, it is just so debilitating where you just, and you get in the spiral of thinking, you're a terrible person, you're not worthy, terrible thoughts like that. Writing, again, when you feel good, be like, I am a wonderful person. I am deserving. I love my body, whatever it might be. And then know that you can go read that thing when you're feeling bad. And that's the truth, not what your brain happens to be telling you right now in this tough moment.
Yeah, that's really good. I used to do something like that similarly when I was going through my depression. I would just write a list of things that are good in my life so that when I'm going through hard days, I can look at that and remember that of the reasons that I should be living. And so that makes so
Yeah.
much sense. Well,
Yeah, it's that gratitude that is so important. And yeah.
yeah, I heard something recently that said the two biggest drivers of debilitation is fear and anger. And the one thing that could make that not exist is gratitude and love. And without those, you will feel the anger and fear more and it'll debilitate you in your life. But if you can just force yourself to feel gratitude and love, it will make those other emotions be less. And then whatever you then focus on will become your life and your habits. So I think that's really strong. It's really hard to be grateful when you're depressed or in a bad mood,
Yeah.
but it's so critical we do that for our mental well-being. So where can people find you if they wanted to work with you? Do you do telemedicine? I mean, if you can share a little bit.
Yeah, absolutely. So I'm on Twitter and Instagram at Laura Buchanan, MD. I've got an agingsuccessfully.substack.com where we just write blog posts about different topics related to aging well. And then I am accepting new patients for both primary care as well as metabolic health focus. And if you go to drtro.com, you can see the different programs that are offered and sign up with me. And that's across the United States. So licensed in pretty much all 50 states almost. And if there's a state I'm not licensed in, happy to get that quickly for you.
I have a question about that. So a lot of my clients, the next question they'll ask is, do you take insurance?
Yeah, so we do not take
Oh,
insurance.
okay.
We will often bill the insurance companies, but honestly, the reimbursement is not anything significant. So I just say, it's basically a cash per.
Okay. But they can try to get their insurance to cover you through out of network. Is that correct?
They can,
Okay.
yeah. It's just really tough.
I know.
Insurance companies do not. I wish they did, but it's
Yeah.
yeah.
I try to get our blood work covered through insurance and as an out of network and the back and forth for all the different insurance, what they want from us, what they need, the line items of all the different lab works. It is insane
It
what they
is.
request.
Yeah, it is. It's such a process.
And I feel that they do that just so that you can then say next time, I'm never going to get something that's not covered, or it's just a hassle or a lot of back and forth. So that's so much trouble that it's just not worth it. Or the practitioners say they won't cover it. And it's just, again, it's putting you in the guidelines. So if it doesn't fit that, don't even try to do it.
Yeah, exactly. Yeah. It's the one of the worst things about medicine, prior authorizations and working with insurance companies. But
Yeah.
yeah, but the other way we are trying to, hopefully help get out to more people is by working with employers. And then the employers can actually pay for their employees to be seen and taken care of us by us. And we've already shown and published in a small pilot of people that we have saved the employers $4,000 per patient per year based on medication deprescription. And so that is a really successful model that we're hoping to continue to expand because it's a win for everyone. The patients are getting better, their work productivity is improving, and the companies themselves are saving money actually on deprescription.
Yeah, yeah, no, that makes a lot of sense. And I think Rivero is another company that's also trying to do that, is to prove by per patient case that they can save money. And so hopefully, if the insurances won't adopt this immediately, that at least maybe through companies that we can get more coverage of this and this type of model so that low carb and other lifestyles can be implemented so that people can heal. So that I'm excited. This is all
Yeah.
good and wonderful news.
Yeah.
Well, thank you so much again for your time.
Thanks for having me.
Yeah, I love the conversation. So thank you again.
Yeah, it was so nice to meet you, and I look
Yeah.
forward to talking to you in the future.
Yes, thank you. Okay, guys, I hope that this interview gives you other tools and levers to use to get to root cause healing. Sometimes we just need to implement things such as CGMs or writing down what we plan to do in a day or our course of our goals and our plans to get to healing. Sometimes it's doing these little things that will help us to be consistent. Find your level of diet restriction to help you ultimately get to root cause healing. And for everyone, that level is different. Okay, guys, make sure to eat a lot of meat. Take care of your bodies because it is the only place you have to live. I will talk to you later. Bye, guys.